first part series, episode number 5. We have a very distinguished guest coming up onto our show today. He's a musculoskeletal, sports and pain physician. He's also a part of the teaching faculty, an examiner for the World Institute of Pain. Now, without any more further delay, I would like to present to you all our special guest for today, Dr. Stanley Lam. Welcome to the show, Dr. Stanley Lam.
Hi, Richie. Okay, and ladies and gentlemen, very nice to see you here in this platform. It's fantastic. It's nice. It's nice way of sharing what we are doing and then what we know, and then in this special moment of we all know the crisis for the world.
So, Dr. Lam, why don't you ask you? So, what is your profession, and how long have you been doing it for?
I'm a specialist in family medicine in Hong Kong, and with special interest in musculoskeletal medicine, sports medicine, and pain management. And I have started my current specialty since 2007. And I'm the clinical associate professor, Honorary, in family medicine in the Chinese University of Hong Kong since 2010. And I'm the honorary clinical assistant professor in family medicine in the University of Hong Kong since 2004. And I'm the president of the Hong Kong Institute of the Musculoskeletal Medicine since 2017. I'm the founding president of the Musculoskeletal Ultrasound Asia Pacific since 2015. And I'm the honorary consultant for the Taiwan Association of Prolotherapy and Regenerative Medicine since 2014. I'm the teaching faculty for musculoskeletal ultrasound in the United States of America since 2011. And I'm teaching the faculty for American Association of Orthopedic Medicine since 2012. And I'm the teaching faculty and examiner for the World Institute of Pain since 2018. So it's sorry about the extensive list.
But that's a very, very good comprehensive list. It's good to have a good understanding of your fantastic background, Dr. Lam. So my next question for you is, what is the type of setting that you're based right now?
So I'm in solo private practice in Hong Kong now. And my practice is basically seeing 3 main groups of patients. The first group is those patients with musculoskeletal pain, mostly from daily problems. For example, your poor posture and your poor biomechanics, and leading to so-called degenerations. The second group is sports injuries of different kinds. And we have many elite sportsman patients as well. And the third group is the patient with chronic pain from head to toes. And usually that is a group of patients with failed back syndrome or due to many traumas and maladaptation and nerves compression or poor compensation. So that's those group of patients, usually they fail to responding to many other treatments. So they come to see us.
So what is your role within the healthcare system, Dr. Lam?
That's a good question. In fact, even I'm in a solo private practice, we still have different roles in different levels of the society and the healthcare system. In the government level, we are actively participating in giving our viewpoints and our input and to the healthcare policy makers in order to help them to make more appropriate healthcare policies to help more patients. I think that's in the government level. In the community level, I have been actively participating in teaching the community especially about how to prevent the general public from developing different kinds of pains and degenerations, which are in fact preventable. And by giving health talks in the church, going to the TV programs, and also to the radio programs, and then writing some articles in the newspapers, and then trying to teach the community. And of course, I also actively participating in teaching other doctors about the musculoskeletal medicine, about sports medicine, about the pain management, by giving talks and then lectures, practical workshops, and organizing different certificate programs. And so that's in the community level. In the clinic level, of course, by running a private practice in musculoskeletal pain and sports medicine, and also pain management, we try to see as many patients as possible, and trying to help them to get the best quality of care and the highest standards of care and pain management as much as possible, as what we can do as possible.
So in terms of expertise, may I kindly ask, what are your expertise?
So my expertise, basically two. Okay, first is to find out the root causes of patients' neuromuscular pain. And the second is to treat the root causes of neuromuscular pain by regenerative injection therapy. And I tried to aiming at minimizing usage of surgery, unnecessary surgery, I would say, and also steroid. And then basically what we try to use, and of course, we try to dig out the patient's root cause of pain by doing a very detailed history taking, and by doing critical neuromuscular examinations, orthopedic examinations, and also to use my dynamic ultrasound, and then trying to find out and then try to visualize, and also let the patient to visualize and what are their real problems, and then what are the root causes of their pain. And also I try to prove whether that pain is really causing the patient's root causes of pain by trying to reproduce patient's pain. Sometimes I use dry needle, sometimes I use my own digit, my own finger, and sometimes I use paper clip. And then by using the paper clip and then under ultrasound, I just press onto this painful spot and then try to localize that spot. And if I can localize that spot, and then I can use dry needle and then right to the suspected lesion, and then trying to see whether I can reproduce patient's pain. If I can reproduce the patient's pain and then I leave the needle for 5 to 10 minutes, and when I remove the needle, and most of the time the patient will get some relief. And then the patient will say, oh, that's really my root cause of pain, because when the needle is really touching this suspected lesion, and then that will be, oh, that's exactly the pain I'm having every day. So that's reproducing of the patient's pain, I think, is the best way to let the patient know that you are really treating the pain. You are really, understand the patient's pain. And of course, to take away patient's pain, I will also use other methods to correct patients' biomechanical anomalies, and then trying to help the patient to correct their postures, muscle training, and then trying to change their daily routines, and then their settings of the office, the settings of their housework, and try to use the forces ergonomically, and then good sitting posture, good standing posture, and then I would try. After that, if the patients fail all the conservative treatments, and then we're trying to help the patients with some sort of ultrasound-guided interventions like injections. So basically, I'm using glucose for prolotherapy, and I'm trying to treat nerve using 5% dextrose. That's also glucose, and then to treat with a hydrodissection. And then sometimes I will use patient's own blood, like own platelet-rich plasma, or patient's own bone marrow aspirate concentrate, and then trying to regenerate the part really damaged and improved by our physical examination, our history taking physical examination, our diagnostic dynamic ultrasound, and diagnostic dry needling or diagnostic blocking. So that's basically my expertise, and trying to help the patients, trying to regenerate, trying to find out the root cause and trying to stop the root cause, trying to stop the pain, and then trying to prevent the patient's pain from coming back. So that's my expertise.
How has your methods of diagnosis and treatment changed over the years?
Okay, I would say being a doctor, when we are seeing a patient, okay, for example, when you're seeing a patient presenting with medial knee pain to your office, I would say we treat what we see, and we see what we know, and we know what we learned and retained in our brains. So you're only seeing something you really know, and you're really treating the patients, according to the knowledge you have. Just like blind people, a blind person touching a group of blind people and then trying to touch elephant. And then the touching different parts of the elephant will opine the elephant differently. Okay, so take medial knee pain as an example. A patient with overpronated feet will also cause, when the feet is overpronating, and that will cause the tibia from, also in internal tibial torsion. That will also cause a lot of extra stress over the medial part of the knee, excessively over the medial meniscus. And it can also be due to trauma when the glue max is not functioning, which is very common, when your quadricep and hamstring are not functioning that well. And then that will also easily cause trauma to a medial meniscus and medial collateral ligament. It can also be happening in a young elite sportsman when they damaged or strained overstretching of the aponeurosis of the pes anserinine tendon, and then causing the snapping of the gracilis between the semimembranosus and the sartorius. So when the patient is trying to flex and extend the knee joint, the snapping of the gracilis will also causing impingement of the saphenous nerve, and then causing the pain during running, during jogging, during jumping, and then basically snapping, basically flexion and extension of the knee joint. It can also be happening in patient presenting with so-called lumbar spondylosis. In fact, I don't like the spondylosis. Spondylosis only means the doctor only knows degeneration. So a patient presenting with like a facet nerve root impingement of the L2 to L4 nerve root levels, they can also causing refer pain to the medial knee region. So a medial knee pain is really something, can be due to many causes. So in order to find out the root causes of pain, I would say initially I learned the osteopathic manipulative skills and learned the somatic dysfunction. And then people knowing the somatic dysfunction, that it is because of the biomechanical anomalies, it's because of the dysfunction in the somatic system. And then that the pain is usually a consequence, a presentation, a causing for help by the patient. The patient's own self body is asking for help. It's asking the patient to pay attention to that part of the problem. So that's why when we look at the patient presenting with medial knee pain, we need to have a very good, very detailed examination, a detailed history, and then trying to see what's really happening around the time when you develop that pain. So, and then go back to the very beginning when the patient's developing different kinds of problems, which the patient may already forgot. Chronologically, I will ask my patient to try to describe. Okay, so after that, when we go back to see my patients, we still see our own limitations. And then I still see that, okay, I may miss something. So I need to learn different skills, different viewpoints, and then from different perspectives. So you're coming from musculoskeletal medicine, you're coming from osteopath perspectives. You know this is somatic dysfunction. You're coming from pain perspective. You know this is so-called, okay, this is nerve, and this is so-called some pain generators. And you're coming from sports injuries, you're going to see, okay, this is biomechanical, and this is so-called strain and sprain injuries. And so from different perspectives, we know that we have limitations. Even you do the physical examinations, you know, the orthopedic examinations, the musculoskeletal examinations, and the neurological examinations, they all give you some hints about the causes of patients' pain, but they all have limitations. So that's why I urge myself trying to incorporate all the different knowledges and different skills into my own way of doing, my own way of history taking, my own way of physical neuromuscular examinations, my own way of ultrasound. In fact, I started to learn ultrasound since 2007. And then I started to learn systematic ultrasound since 2010. And then I tried to develop my skills of dynamic ultrasound since 2011. I think there is no other ways of imaging modalities which can help you to moving the patient and scanning the patient at the same time to look at what's really going wrong with the patient. When you take an MRI, when you take a X-ray, that you have to stand still, you have to lie still, and then you cannot move. And then, but when a patient presenting like a medial knee pain, most of the time they would say, okay, doctor, I only have pain when I move my knee. I only have pain when I'm going downstairs or upstairs. I only have pain when I squat. I only have pain when I'm running. I only have pain when I'm walking. Okay, there are no other modalities of investigations. You can really scan the patient with the patient walking, with the patient going downstairs, with the patient going upstairs. But using dynamic musculoskeletal ultrasound, I can see that. So that's the skills I developed throughout the years, trying to scan different parts of the body using dynamic ultrasound. I asked my patient, can you reproduce your pain by doing any movements? And then the patient just say, okay, I have shoulder pain. I only have pain when I reach out. I will put the probe down and I try to reach out and let me scan what's really going wrong underneath my probe. I want to see it. My patients want to see it. Okay, pretty much like when you're trying to feel your shoulder is moving, you feel some snapping, right? You feel some clicking, but you want to see what's really underneath clicking, what is really underneath your hand is really snapping. So that's something, the skills I developed because of for the dynamic ultrasound. So for example, when I put a probe down, you see a suspected lesion, okay? Then okay, you want to prove that suspected lesion is really causing the pain. So you can just run a paperclip underneath the probe. Okay, you press. Okay, this is a painful spot. You press with force. You make a depression here. Okay, then you turn the probe 90 degrees. This time you run the paperclip again. You run the paperclip again, and then over the painful spot, and make another skin depression. So with two directions of the skin depression, you already make a cross, and then that cross corresponding to a painful spot. Then you can use the dry needle, using your ultrasound to guide your dry needle right to the painful spot, and then see whether you can reproduce patient's pain. So that's the technique I developed throughout the years. Or you can just basically using local anesthetics and then tiny bit, maybe 0.1 cc or 0.2, 0.5 cc, because you don't want to flush the whole area. Just using a tiny bit of local anesthetics, pass your needle right to the spot and then do a diagnostic block. That is basically, when a needle is touching that spot, try not to inject immediately, and then trying to let the patient feel, and am I reproducing your pain? And the patient said, oh yes, that's exactly the pain. So that's, I think, the something you can prove to the patient, that's you know their pain. And then also the patient is this is the best buying power for the patient. And the patient said, this doctor knows my pain. Okay, and after that, you can just inject a little bit of local anesthetics. You numb that area, just a tiny spot. And then the patient says, oh, that's the best relief I have. And now you start to talk to the patient. I know your lesion already, but I have to say the lesion is only a consequence. It's only a result of so many biomechanical anomalies. And that's my plan for you. I can treat that pain, but I want you to cooperate. To working as a team, trying to change, your way of practice, your way of daily living, and how to exercise correctly, and then trying to basically trying to change their mind, and then trying to change their postures, and so I think basically sometimes I also do because if you find a nerve is compressing by that, I also develop the skills of using the 5% dextrose and to do the hydrodissection of the nerves. If the nerve is impinged somewhere, I can use my needle to guide the dextrose around that nerve, injecting around the nerve without any local anesthetic, and then I can release the nerve, and the nerve can now glide, smoothly within the soft tissue, and then that's also, you can just without using any local anesthetic. If I can release the impingement and to get the patient to pain-free movement, the patient will say, that is good. But at the same time, we still have to think, is the treatment the patient need to have, or you need to prevent something? Can you prevent the patients from pain from coming back? How can you prevent the entrapment from coming back? How can you prevent the patient injury from getting damaged again? So that's the thing we need to have. So I think when I am trying to answer your question about the method, how the method changed over the years, it is changed when we know more knowledge, we know more skills to help the patients. And you have to basically help the patient to treat the root cause and help the patient to prevent the pain from coming back. That means you have to modify the patients and then modify the biomechanics. And but you still have to think an effective way and a less painful way of doing those treatments. So that's why I changed myself. I keep changing myself. I keep improving myself. I've never stopped learning new skills. I never stopped asking questions myself. And then how can I improve myself? And then so every day, if I can think, today I can do this procedure, I can do this intervention in another way, in a less painful way, in a more cost-effective way, in a more safe way, I'll be very happy. So that's the passion to push me to go forward.
Thank you very much. That was a very, very comprehensive breakdown of the specific area. I was wondering, my next question now for you is, how long is each one of your sessions? And what is the approximate split or ratio of your session?
Okay, that's a good one. In fact, it depends on whether the patient first come to see me or it's a follow-up visit for the patient. For my new patient, I usually would schedule about 45 minutes to 1 hour for my new patient. When the patient comes to see me the first time, I would take about 20 to 30 minutes asking a detailed question about his or her pain. And then I would dig into the hole and drill down to the root cause of their pain. And I would ask what really happened, chronologically during the period of time in their life when they develop the problems. No matter how trivial the problems, I want to know. I not want to know exactly what are contributing or perpetuating the patient's pain. Okay, so that take a lot of time. So that's why most likely I will use about 20 to 30 minutes asking questions and then asking the patient to elaborate. I will further asking questions and asking the patient to elaborate again. Then I will spend about 5 to 10 minutes doing my critical neuromuscular examinations. And then I would using different modalities. And then I will spend another 10 minutes doing my dynamic ultrasound, asking patient to move and then trying to reproduce that pain, and then let me scan them. Okay. And the first visit, I usually will only do manual treatments plus minus dry needling. I usually will not jump to ultrasound guided injections. I will use manual treatment, and sometimes I would use ultrasound to let them see their movements as visual augmentation, and then trying to teach them how to use correct muscles. And then I would do my osteopathic manipulative skills, and then doing the manual treatments to restore patients' alignment of the spines and joints, and releasing the tight muscle, and then trying to ask them to activate their weak muscles. Dry needle can reproduce patients' pain, and as said, I stayed the needle for like 5 to 10 minutes, and then that usually can release patients' pain, and then the patient will feel some treatment already. And then after that, I will give my management plan to the patient. I will let my patient know that with that treatment, with the manual treatment, with my dry needle, most of the time they can feel partial or complete relief of that pain, but the pain will probably recur like within days or weeks. So that's very common. And then because we still need to go to treat their biomechanical anomalies, and then try say if they have overpronated feet, they probably have to correct their how to correct their overpronated feet by training the small muscles of the feet. And if that is the patient presenting with injuries to the meniscus, injuries to the medial collateral ligament, we probably have to use prolotherapy, even regenerative injection therapy, other type like a PLP, like a bone marrow concentration, bone marrow aspirate concentrate, other type of treatments, and trying to rebuild that part of the damaged soft tissues. So that I would tell my patients when they come back, and then I would give them the information for them to learn themselves and to understand themselves, and then asking me questions in the next visit. And then I will make an appointment for the patient to come back in the next visit. And then when they come back in the next visit, this time if they're really coming back for an injection, the duration of the session will be much longer. I usually will give them a 1.5 hour appointment. And then for 10 minutes, I will review how they feel after how they felt after the first treatment, and then when did their symptoms come back. And then I will do another 5 minutes of physical examination, and then I will do another 5 to 10 minutes of manual treatments, and then to restore the alignments. If they understand and consent me to do the RIT, and I would try to do the prolotherapy or other regenerative injection therapy, I'll be using about 30 to 60 minutes, because that will be under ultrasound guidance. So that's my usual way of seeing patients. So I'm not seeing many patients per day.
So in terms of the overall aspects in terms of homework and correctives, so do you actually give your patients and clients homework as well?
Absolutely. In fact, I always ask my patient, especially during the first visit, I will ask my patient to take picture of themselves. The best way to do is to set a camera somewhere, and then they take a video, and then they doing their usual work, either housework or their clinic or their office work, and then trying to be as natural as possible. I don't want them to sit correctly to let me see. That's useless. In fact, I want to see them leaning forward, head forward, protruding head forward, and or if they are sportsmen, I want them to basically, when they compete, when they run, when they jump, when they're playing sports, and I really want them to take the videos for me to see. And then I try to incorporate all the information into my management plan. I will ask them to correct their biomechanical anomalies, to change their postures, to change their office setting, and then to be ergonomic way and a cost-effective way, and then to prevent the pain from coming back. That's homework number one. If some of their muscles are too weak, and then because of that, the muscles being inhibited, and then I will teach them simple way of trying to release the inhibition and to activate the weak muscles. So that's the homework I'm going to give the patients. But usually I still think if I can have a teamwork like Richie, if you are in Hong Kong, that would be the best. I can have my patients refer to you, and then you can work on the patients, and then we work as a team, and then trying to help more patients. That's the best teamwork.
And are there any advices that you would give people that are new to the field or looking to get into a field?
That's another best one. I think if you are new to musculoskeletal medicine, to pain management, to sports medicine, to whatever this kind of therapy view, I think I advise you to learn with heart. Trying to put yourself into the position of your patients, and then trying to think, to feel what they are really feeling, and then try to think critically how you can help your patients to relieve their pain and then prevent their pain from coming back. And I want you to keep asking yourself questions. And then believe me, there's no stupid questions. There are only questions which can be answered in this way, or in a better way, or a further better way. So I urge you, what you can do is, you can, even myself, I still review my own practice periodically. I try to think, what are the best way, cost-effective way to ask patient history, to do my neuromuscular examinations? What tests are more critical and give me more information? What test I can add on, or what test I can omit? And what are the best way to make the diagnosis? How I can scan my patients more ergonomically correct to protect myself? How I can find the root causes of the pain, and how I can treat my patients less painful, more safely, more effectively, and then to prevent the pain from coming back. Don't think you are offering the best treatment to the patient already. There should be a better way of treat the patient. I always think that way. That's why I keep improving myself every day. If today, when I'm running, I think, I can think of one better way of managing my patient. That is the best day I've ever had. And also, don't stop learning, especially learning anatomy. Even I can tell you, hundreds of peripheral nerves in the body. I'm still learning every day. I'm still learning when I can name all the peripheral nerves in the lower limbs, then you can start to learn all the peripheral arteries, all the peripheral veins. So there must be nerves, there must be veins. You don't know their name. And then those arteries and those veins are going together with some nerves, which you don't know. Teaching cadaver workshops. For 2 days, we're doing the ultrasound-guided interventions like injections, like nerve hydrodissections, disc injections, and then, usually on 3rd day, we are going to do a fresh cadaver dissections on one of the asylum teacher. So we cut through, we expose all the anatomy. We try to cut through the skins and the subcutaneous fat, all the fascias, layer by layers, muscles, ligaments, and then down to the joints, capsules, and then into the joint. We try to move the limbs and the bodies and then pull on the tendons and ligaments, and you see the relationship with the surrounding structures, like pulling on the nerves, see whether they can move a tendon, pulling on the tendons, the ligaments, seeing that whether they can pull on the surrounding nerves. Those are, each time we will be amazed by the body God, produced us. So in fact, we know very little about how our bodies are functioning within ourselves. So that's why never stop learning. Be hungry and be foolish every time, every day, every moment. That's my advice to the newbies.
And now, if you can go back in time to give yourself one piece of advice, what would you give yourself?
If I can go back in time, I think I will push myself a little bit harder. Try to write down my techniques, some of the techniques I developed, which in fact I'm doing at the moment during this COVID-19. I try to write down the techniques I developed throughout the years, and also trying to write down my failures during each stage as much and as detailed as possible, and trying to share with other doctors. My basic idea is still the same. I want more doctors to learn these skills and to help their patients. I want more patients to be treated and to be pain-free. So that's my basic idea, and that's my passion.
Thank you very much for offering all of your experiences, in addition to providing us with very detailed levels of descriptions. And of course, most importantly, is the insight that you're providing all of us today in different fields. So that's all the time we have on the show today. I would like to thank Dr. Stanley Lam again for coming up onto our show. Again, this is Therapy Tea Time Talk. Have a nice day.
Have a nice day.